introduction before passing the baton over to Emmy Malone, who is going to MC us through the rest of this program. But just very quickly, I always like to mention that the Betsy Lehman Center is a relatively new Massachusetts state government agency, relatively new in terms of government agencies. We've been around for about a decade now, and our history is we were. I also like to say we're the only state agency named after a person, and some of you may remember that we're coming up to 30 years now, but we are named after Betsy Lehman, who was a nationally known, very highly regarded Boston Globe health reporter, columnist, and young mother of two she had two girls who were preschool, elementary school age when she was being treated for metastatic breast cancer, and died as a result of a massive overdose of chemotherapy in the course of her treatment. And that event, because of who she was and being a journalist, being a well-known journalist, and who had friends at the Boston Globe, they really ran with the story for about a year, and her death really triggered the start of a national patient safety movement. And we've, over the years, there's been a lot of progress in this space, but we are still very, very much challenged in the area of preventable harm to patients, which harms obviously patients and has impacts on their families, and really kind of reverberates through the entire healthcare system and beyond. And so the legislature, the Massachusetts legislature, created us to, as a non-regulatory independent agency that would really play an important convening and coordinating role, and also data collection, analysis, research around really focused on preventing these kinds of harm events through major improvement initiatives. So one of the things that when we got started, I didn't think we would be doing, but we have, is get involved more on the programmatic side. So we have now 3 programs, including this new one to support the patient family advisory councils. But the earlier 2 are really focused on supporting patients and families in the aftermath of harm events. And this one, when we think about the potential for PFACs, it's really to engage patients and families, and really bring that voice into the prevention and improvement side of things. And so we are very excited to be sort of relaunching this work, which some of you may remember that up until maybe 5 years ago, Healthcare for All had a program to provide technical assistance to hospital PFACs. And just that work has not been funded recently, and so we've now brought that work on board, and we'll be really looking to develop this program going forward. Really, also just bringing in your perspectives in terms of what's needed and where we can be supportive. And so this initial gathering that we are hosting is really focused on fostering connections among members of PFACs from different provider organizations, and we're just very excited to get started. So without further ado, let me turn it over to Emmy, who will introduce herself and lead us forward.
Great. Thank you. Thank you, Barbara. Thank you, everyone, for joining us tonight. I'm Emmy Malone. I'm the Deputy Director of the Betsy Lehman Center, and I've been leading our recent work to try to be an organization that can be more supportive of and helpful to the patient family advisory councils in Massachusetts. Before I jump into our agenda, for some reason, Zoom decided to name several of you as you came in with the name Kim Lay. And we would love it if you would just change your name on Zoom so we can see who you really are. And the easiest way to do that is to simply bring your cursor over your own picture, and then you'll see in the top right-hand corner 3 dots. And when you click on those, one of your choices is rename. And so you can type in your true name. So it's a really interesting little glitch that I haven't seen before. So forgive us for that, and thank you for making that correction. So our agenda this evening, as you know from the invitation, involves 2 presentations, one on engaging with leadership and a second one on diversifying PFAC membership. And so for our first presentation, so we will do each presentation back to back and ask you to hold your questions during the presentations. When both are completed, you will have the opportunity to join a breakout session. And so one session will be focused purely on the leadership question and the other one on the diversifying PFAC membership question. Our speakers will be in those breakout rooms, so that will be the opportunity for you to interact both with them and with one another. And so we will give you a little further instructions when we get there. And after the breakout discussions, we'll come back all together for the last 10 minutes and wrap up and discuss some next steps. So before I dive in or introduce our first speakers, we just thought we would ask all of you to answer a very quick poll that it's really 3 questions that will give us a sense of who's here tonight. And so if you're able to see that on your screen, you'll see there are 3 questions. One is just asking how long you've been involved in PFAC. And the second one is if you would just tell us what your role is in the PFAC. And the third one, I admit, is a little bit of an obnoxious question where I ask you if you have to pick one reason why you're here tonight, just choose one. I'm sure many of you here are for multiple reasons, but it's a little bit bratty, but I think it's just be interesting to see what motivated everyone. Janelle, why don't you go ahead and end the poll, and we'll just take a very quick look at the results. So it looks like almost half have been involved in PFAC for more than 4 years. That's great. And then we have organization representatives as well as patient family advisors. Terrific. Thank you all for being here. And the last one, the diversifying membership topic seems to be top of mind for many people. So terrific. Thank you for answering that. So our first presentation tonight is going to be about the relationship between PFACs and leadership at institutions. And leadership can be defined in a variety of different ways, and I'll leave that to Michael and Monique to further discuss. So Dr. Michael Gustafson is the Chief Executive Officer of the Schwartz Center for Compassionate Healthcare, which is a national nonprofit organization dedicated to putting compassion at the heart of healthcare. Prior to joining the Schwartz Center, he served as president of UMass-Medical Center, and so he'll speak with us today about his experience with PFACs during his tenure at UMass. And he is joined by Monique Manna, who has served on the Medical Center PFAC at UMass-Memorial Center since 2021. The Medical Center PFAC is one of several PFACs that advises UMass-Memorial Health System. And I'll leave it to Monique to tell you all more about her experience as a patient and how that drew her to the PFAC work. And then just as a reminder, if you kindly hold your questions for our speakers for the discussion sessions, which will follow the second presentation. And so I will turn it over now to you, Michael.
Awesome. Thanks, Emmy. I'm so thrilled to be a part of this summit on PFACs. It's a subject that's really near and dear to my heart. So thank you all for taking the time to participate. I'm actually going to spend the first 5 minutes or so talking about my experience with PFACs at a few other institutions. So I'll touch on the Dana-Farber, the Brigham, and the Faulkner, and then I'll transition to my time at UMass, which will transition then into Monique talking about her role on the PFAC there. So, but I wanted to start by just saying that one of the key things in terms of engaging leadership is to find leaders in your institutions who are really passionate about the patient-family experience, patient-family centered care, about involving patients and families. And I know there are a lot of them out there in our institutions in Massachusetts, fortunately. And it's something that for me as a surgeon, as a provider, then moved over into running hospitals, allows me to really tap into the reason that I went into care in the first place, which is really to optimize the patient and family experience. So I've been fortunate to be a champion of that close to 30 years. So, at the very beginning of my career, I was exposed to the Dana-Farber Brigham Patient Family Advisory Council, which was really, I think, formative. I really saw firsthand, this was in the 1990s, the power of involving patients and the families in helping to think about real issues. In this case, it was the Dana-Farber and the Brigham coming together to provide inpatient care, actually after the Betsy Lehman incident. So patients and families were intimately involved. And some of you may have been involved going back to that phase of history. But thinking about the impacts of the two institutions working together. And so it's much more than just patients walking across the bridge between the two places, but thinking about how care actually was truly integrated. And then bringing the voice to both parties, to both the Farber and the Brigham. So that has always stuck with me. I was able to be the chief quality officer at the Brigham for about 10 years. In that role, I had a chance to partner with our CMO and our CNO and really creating the first PFACs at the Brigham. We embedded that in the early patient-family relations departments that we were developing. And we tied it to a real commitment around patient experience. With our president at that point, we had an aspiration of moving our patient experience scores which were essentially about average, maybe the 50th percentile, to being in the top 10 percentile. And so we laid out a 5 to 8 year plan to be able to do that. There and at Faulkner and at UMass, I think about patient experience journey as tapping into a set of best practices. So in each of those places, I've created a model, I think a holistic model of patient-family centered care. And so that means there's a role for leadership, there's a role for measuring and getting very active feedback, both surveys as well as tapping into comments and feedback and letters from patients and families. It means sponsoring hospital-wide improvement work, making sure there's department improvement that's going on, that there's training for staff in patient-family centered care, and importantly, a body of work. And I really tapped into the Institute for Patient-Family Centered Care around patient and family engagement. And I always think about that as engagement from the various highest levels of the organization. So at the board level, at the leadership level, helping to think about organizational policies, all the way down to patient and family involvement at the bedside in daily patient care, right? And everything in between is, to me, the essence of patient-family centered care. So really tapping into that framework was really helpful. I used there's a framework that the Institute has, which you can, as an institution, do a gap assessment to see, are you doing these various components that truly embed patients and families in all aspects of the hospital. That was really useful to educate the other leaders in the institution where we were on the continuum, and then to start to close those gaps, to change the culture. one of the things I wanted to mention at the Brigham, we did a ton of improvement and innovation work. And one of the things that was really powerful was actually bringing patients and families into those improvement activities. Whether you're doing a week-long Kaizen event or you're doing other sorts of performance improvement interventions, actually getting folks that are impacted by the care to participate in the improvement was really rewarding. So I would highly recommend that, as well as having folks be involved in the more traditional committees at various levels of the hospital. Certainly I've also taken advantage whenever you're doing anything new, so a new building, a new space, a new program, a new procedure, it's the perfect time to have patients and families think about all the aspects of that new opportunity. And it can be really fun and exciting. When I've been at UMass, I'll talk a little bit about our approach there. We there and at the Brigham, I think it starts making sure that the patient experience and the patient family experience is built into the strategic goals, into the strategic plan. So there at UMass, I had 8 key pillars, one of those being the patient experience. And then under that patient experience pillar, developing a 5-year roadmap. And again, laying out how do we become a patient family-centered organization. And it's not going to happen overnight, but what can we do this year, and what do we do the next year, and what do we do the year after that to build on that? So I really enjoyed working with our PFACs at UMass. There we had a hospital-wide PFAC, as well as several specialty areas. So for example, the NICU and in cancer, which was relatively new. I have found there and at the Brigham, the subspecialty or specialty PFACs can add a lot of value because some of the issues in care are really unique, but also coming together as an umbrella PFAC and sharing those findings can also be really useful. UMass also had a system sharing of the PFACs across the community hospitals in UMass. I think that was also really helpful because more and more patients are traveling between hospitals, right, and experiencing the system of care. So maybe thinking about PFACs sharing across hospitals at that level. We included our PFAC in several major initiatives. First of all, when we came up with the idea of a patient family-centered care model, they were absolutely involved from the beginning and critical to helping us define that. We had to define what the patient experience was. So going through that process with our staff and with patients. But then tackling some bigger issues. So for example, we, after COVID, when we were struggling with our workplace violence and a number of assaults from our staff, we developed and implemented a patient visitor code of conduct, right? It's really tough because it's striking this balance between, open access and family presence versus some of the challenges that happen in terms of our violence with staff. So it was really critical to have direct patient feedback and input along the process, both as we had the idea, but also as we wrote the code of conduct, and then we thought about how it actually be trained with staff and implemented with families. I think I can't think of a better example of how important it was to have a voice there. And then the last year before I left, we wanted to launch a Care Partners program, which was equally dependent on the patient family input. Care Partners, as we define it, was basically anybody who is essentially helping a patient with their care, the navigation of the system, whether that's in the hospital or across chronic disease, outpatient, et cetera. Everybody needs a care partner, essentially. So defining what that meant, getting the institution comfortable with including care partners, and then figuring out what a launch and communication strategy. And that in itself will also be a journey, but I'm really proud that we were able to do that before I left UMass. So I think I've touched on most of what I wanted to land on. I did have at UMass the chance to meet with our PFAC at least once a year. They had a monthly meeting, so I would go to the dinner meeting At that meeting, I typically would present our strategic priorities for the year. I'd talk about our strategic goals, do a deeper dive on quality, safety, and patient experience, and engage in some dialogues on some of those initiatives, and be really transparent around, we have a lean management system with a very transparent set of metrics. So being transparent with how we were doing each year in terms of making progress. And we also then rotated other senior leaders through through that dinner meeting so that they could have a similar discussion. So maybe with that, I'll hand it off to Monique.
Thank you, Michael. Thank you, Emmy. And I'm very happy to be here tonight. I will be honest with you, I'm a little nervous. I get camera shy sometimes, but I'll get over it. So my name is Monique Manna. I am a PFAC member since 2021. I am a mother of 6 children, and I have 5 grandchildren. Back in October of 2020, I was diagnosed with high-grade osteosarcoma. It's a primary bone cancer. They found the tumor growing out of my femur. However, if you look in one of those pictures right there, you see me sitting down and then you see some glaciers. That was 3 months before my diagnosis. So who would have thought I had a tumor growing out of my femur, climbing like what I consider a mountain. I was out in Alaska. And that middle picture is my family there. So like I said, I had a tumor that was growing out of my left femur, and on November 9th, 2020, my first day of chemo, I came home from chemo after chemo, and I knew that I had to be careful with my leg, and so I was being very careful. I carry it, and to move myself out of the car, but my femur could not take the growth anymore, and it spontaneously snapped. And that's how I ended up over at the UMass campus over on the 8th floor of the cancer wing for a month and 3 days. And that's where I met the most fabulous nurse, Kathy. She was my constant. That's me. It's a reunion about a year and a half later. Her and I had, and I'll talk a little bit more about that later. But yeah, I've been a PFAC member since 2021. The PFAC that I am on is just one of 8 PFACs. And I discovered the PFAC while I was at an appointment with at my orthopedic oncologist's office. I saw something come across the screen, and I got a glimpse of it, and I'm like, oh, I wonder what that is. And so it came around again, and I actually took a picture of it, and I got some more information on it. And I emailed the email that it told me I had to, and I got a response, and they direct me to their website to fill out an application to become a PFAC member. And it was Billy Adler. She's the PFAC program manager. She is the one that reached out to me. She onboarded me, and she also recruited me for the gratitude video that they were doing during the Patient Experience Week for 2021. And I believe Emmy has the link to that, and she's going to share that with you in the chat. But you can also take your phone, and there's a QR code there if you want to watch the video itself. But that's when I was reunited with Kathy back in 2021, my nurse Kathy, and she was my constant. She let me know her schedule, when she was going to be on, when she was going to be off. She was the nicest person. She was the first face that I saw when I was wheeled into that room, and where I made my home for the next month and 3 days. She was always with me when she was there. She was just so wonderful. She means the world to me. Anyways, Eventually, I ended up selling my house, and I decided to move to Kansas because, being disabled and I was single, my house was too large for me to take care of by myself. So my oldest son convinced me to move out to Kansas, and I moved out to Kansas to be closer to him and some of my grandchildren out here. But with being able to, with the ability of working remotely, it serves a great deal because I joined the PFAC, all remote. And I also assist Billy with some of her projects. And I also attend some of the focus groups remotely when my schedule allows. So that's a little bit about me. This slide will just show you some of the representation that our PFAC members are on for the committees. And you see down at the bottom there, the Schwartz Round Planning Committee. Well, I believe Michael can talk more on this in the when we have the breakout rooms. This slide it represents some of the engagement that our PFAC members had. For example, the new inpatient building, which is now named, I believe, the North Pavilion. Some of the PFAC members involved on this, they were invited to public hearings, and they got to voice their experience and why they felt the importance of the project should continue to go through. And they also did tours, and again, they did testimonies at a public hearing, and they were part of the determination of need. And well, on their facility tours, some of their ideas and recommendations for the changes were incorporated with in the process and with this building. And I believe this building is slated to open January of 2025. And we have some on the food services program. If you see in the picture there, those are a couple of the PFAC members. They were in a conference room, and they were role-playing patients. And this was for the At Your Request program that the food department was doing. It's like a it's like a room service. So they were pretending to be the patients, and they did a role playing of the patients, and they put their order in. And I believe the food facilities department, they had all their information. And I'm not sure if they asked for something they weren't supposed to or anything, but whatever they ordered, they were actually able to eat at the end and taste. They did a taste testing too, from what I understand. And then, of course, the Care Partners program, which Michael can talk more about there. And I believe there's a link for the video. I'm not sure if M.B.A has that. If not, I can find that and I can put that in the chat. And then some of the patients were, some of the PFAC members were involved with the ED Patient Experience Project. And this was a project for a graduate student, Sharon Rudinsky. This was her program. And they were asked just a bunch of questions about signage, the website, and whatnot. And this helped. They were able to help her with her project. These are just some of the testimonials, just a few here about the positive impact. And there's one that I'm going to read, and it's from one of the PFAC members, Kathy Buchanan. And she writes, "In the 4 years I've been a member, we've established ourselves as a legitimate voice for the patient. We now have members who serve on influential committees like the Patient Care Assessment Committee and other high-level committees. I am proud of the work we are doing." That's it.
Okay, great. Thank you, Monique. You did fabulously. I would never have known that you were nervous. Okay, so thank you both to Monique and to Michael. And now we'll go to our second presentation. And for that, we will hear from Pam Dardess. Pam is Vice President of Strategic Initiatives and Operations at the Institute for Patient and Family-Centered Care. And if you haven't heard of them before, hopefully you'll look them up after this. The center is really a very active supporter of patient and family advisory programs across the country. And among the many bodies of work that they have is a series of strategies to help patient and family advisory bodies diversify their membership. And so with that, I will turn it over to you, Pam. Thank you for joining us.
Thank you so much. So I'm delighted to be with all of you here this evening. I recognize a lot of names and faces and look forward to meeting more of you. So during our time together today, I'd like to share a few learnings from a national survey that we did of Children's Hospital PFACs that relate to diversity, equity, and inclusion. And then I'll be talking about 6 specific opportunities for action. I do want to acknowledge that we have been fortunate to be supported by the Lucille Packard Foundation for Children's Health for this work, and really appreciate what they have been able to contribute. So it's no surprise to all of you in Massachusetts, where PFACs are mandated, that PFACs are a really important part of partnership with patients and families. But to share some context nationally, in 2020 and 2021, we did a survey of all U.S. children's hospitals. We received responses from nearly 3/4 of all children's hospitals. Of the hospitals that we heard from, 88% reported having at least one PFAC and 8% had a PFAC in development. We also found that many hospitals had multiple PFACs, including specialty PFACs like Michael spoke about. So the other thing that we heard, which is probably not surprising to all of you, is that PFAC diversity is a challenge. So 62% of the respondents identified difficulty recruiting or retaining patient and family advisors who reflect the diversity of their patient and family population as one of the 3 most significant challenges that was facing their PFAC. We also did some interviews to supplement the survey. We heard the same thing again in the interviews. And what we heard more specifically is from PFAC coordinators that despite best efforts, there were critical voices that were missing at the tables when PFACs are gathering. So not surprisingly, people tended to report that their advisors were likely to be older, white, female, and to have higher levels of income. We had one interview participant share that they took an initial look at their data about advisors several years ago and showed that 82% of their advisors were white, 65% had a master's degree or higher, and 73% had a household income of at least $150,000. This was not a good reflection of the diversity of their patient and family population, so this led them to develop some intentional goals then around increasing diversity. The other thing that we asked about is the extent to which advisors are connected to work that's being done in the hospital related to diversity, equity, and inclusion. I noted when Monique was talking that they have advisors who are serving on a diversity, equity, inclusion, and belonging committee, which is great. That at the time of our survey was not happening with a lot of the survey respondents. Only about 1/4 of them were working with advisors in this way. This is a long quote. I'm not going to read all of it, but I am going to encourage you to come back to it in the slides. Happy to share that afterwards and Emmy, happy to have you all share those slides. This is a quote from a PFAC coordinator at a children's hospital, and what she is doing here is connecting the lack of representativeness in PFACs, particularly from historically underrepresented and marginalized communities, to closing equity gaps. So as we're looking for ways for PFACs and advisors to really help address some of the most important issues that are facing our hospitals, obviously health equity is a really big component of that. Patient and family advisors are better positioned to help address health equity when we're hearing from populations and communities that have traditionally experienced the most harm and the greatest inequities. So beyond the risk of leaving out certain populations, this PFAC coordinator mentioned that, we also run the risk of contributing to the trauma and the harm when we are not learning from a diverse group of people. So with that background, I'm going to share some specific opportunities. This is just a little bit about where this information came from. We undertook a literature review. We did some key informant interviews with people working in children's hospitals and other child-focused both health and social service organizations. We also conducted focus groups with patient and family advisors themselves who identified as being from underrepresented and historically marginalized populations. So the opportunities for action that I'll talk about, I want to frame them up a little bit. Across the opportunities, what we heard from hospitals is that there are a couple of overarching principles. So first, improving diversity is a very broad objective. So they spoke about the importance of breaking that down into specific goals. What does it really mean to improve diversity within your PFAC? Second, to listen to and learn from communities and populations that have been historically underrepresented about barriers to participation and what might be needed to address some of those barriers. And then third, identify specific intentional actions to help achieve goals. And that progress is not linear. It may go forwards, backwards, up, down, side to side, but it's not a straight line as we do this work. Above all, what we learned from hospitals that have had success on their journey to diversify their PFACs is that it required them to work differently, not harder. They shared that they tried, following some of the same processes for recruitment, for example, that they had done before. They found that regardless of their efforts, without trying some new things, that it was yielding the same type of patient and family advisors that had been recruited in those ways before. So as we were working on developing some best practices, we looked to these hospitals that have been successful. We also looked to other fields where there's a strong history of partnership, particularly community engagement and community-based participatory research. So getting to the opportunities for action. The first opportunity for action is related to data and goals. In Massachusetts, you have a little bit of an advantage because the PFAC annual report that is required does ask about the makeup of the patient and family advisor population, talks about comparing it to the catchment area and then the patients served by the hospital. But for a lot of hospitals, they may not have access to this type of information. In Massachusetts, it's something you're being prompted to think about from the beginning, at least in terms of certain demographics for advisors. But understanding the picture here is helpful for the first big task and developing a clear understanding of what it means to have a diverse group of advisors on your PFAC. So it means obtaining and looking at data to help you understand your patient population and your advisor population and where there may be some gaps. Now, it's also the case that data and numbers might not tell you everything in terms of just looking at demographics, because you very likely don't have data and information about every single aspect of diversity, because we know diversity can be thought of in many ways: race, ethnicity, gender, sexual orientation, language spoken, disability, health status, religion, urban or rural location, type of insurance, many different things that can comprise diversity. So hospitals that we talked to developed goals for diversity in a couple of different ways. Some focused on a particular aspect of diversity as their initial step. So for example, improving racial diversity on the PFAC, and that was where they concentrated their efforts. Others looked to data on health disparities within their hospital and identified several populations that were at highest risk for disparities, and that's how they identified some priorities for recruitment. Other hospitals have looked to comments and feedback from patients provided to the hospital to identify priority populations. So in short, there's no one right answer here for how to define diversity. I can't give you the prescription, but I can say that there needs to be some careful, intentional work that is built around as much data as you have to define what diversity means so that you understand whether and how you're making progress. The second opportunity for action is to re-examine recruitment. So thinking about how to perhaps do things differently. One way to improve recruitment is to make diversity a shared goal of the institution. So you may have healthcare providers and staff who help identify patients or families who are good candidates as patient and family advisors. Several hospitals that worked on their recruitment procedures did so by reaching out to let providers and staff know about their specific goals for improving PFAC diversity. So for example, letting staff know that they were particularly interested in individuals who did not speak English as a first language, or who lived in rural locations, or who had Medicaid. So stating what the goal was and being very intentional with that as they communicated with staff about recruitment efforts, positioned them to help achieve that goal. Another part of recruitment is by strengthening relationships between the hospital and community. So I think, as we all know, oftentimes there's a lack of trust in healthcare organizations that has been built up and formed over many years. And you may need to look for ways to build relationships that begin to bridge that lack of trust. There are hospitals who sought out groups within their hospital departments that did more community outreach, or clinics who were working with specific populations. They learned where some of the relationships existed with populations they were trying to recruit, and worked to make connections within the hospital. They also thought about ways to show up outside of the hospital in the community consistently. And what they told us, actually, this is what we heard from community organizations, is that there's a need to show up without the expectation of a transactional interaction. So don't just show up to recruit, 3 or 4 people. Attend community events, attend cultural festivals, have a table, offer health screenings, provide health information. Show that you are showing up for the community because you care about us, and begin to build relationships that way. That will also incidentally help you get some feedback about potential barriers to serving as advisors. So for example, some hospitals based on feedback have re-examined and simplified their recruitment applications to be more literacy friendly. Another thing that I want to talk specifically about is background checks for advisors, because I know this is a topic that comes up frequently. There are some PFACs that have successfully argued for moving away from background checks. There are other hospitals that, recognizing that this is a potential barrier for recruitment, have developed tiered participation structures. So for advisors who are on site, who might be interacting with patients and families, they do go through a background check. Advisors who participate virtually or at meetings out in the community may not need the same level of clearance. Another thing we heard that can be a barrier is, the time, the money, and who has the privilege to volunteer as an advisor. So stipends for advisors is another emerging topic. I will say that very few hospitals offer advisor stipends currently, but there are those who do and others who are working on this. So some pay advisors by the meeting, others pay them for specific work, and those who do offer stipends view it as an important part of addressing inequities associated with who can participate. So the third opportunity is to think about structures for engaging. So do you have various options for advisor participation that may help address some of the barriers that you've identified? I've spoken about those tiered participation options. Monique and Michael talked about specialty councils that provide an opportunity for people who share backgrounds or experiences to work together. This may provide what feels like a more inclusive and safe environment. So the University of Rochester has a deaf PFAC. I know many of you have specialty councils. The University of Rochester also has a Black and African American families PFAC. There are LGBTQ+ and gender proud PFACs, Spanish speaking PFACs or consejos. So those are all options to explore. And then there are some hospitals that are exploring alternative approaches to traditional PFACs that better address community needs. So one hospital that we were working with has begun a community council that meets out in the community with flexible membership. So these are advisors, but there's not necessarily the same requirements about attending a certain number of advisory council meetings. It's more of a flexible membership for this community-based group. So as you're working to diversify your PFAC, it's also important to think about and examine the extent to which you're bringing people into an environment that supports inclusion and equity. So we've talked about identifying and addressing some barriers that might prevent full participation. It's also thinking about specific guidelines for inclusion that you're going to apply every single time. Do you state inclusion as a specific goal of the PFAC? Do you have guidelines for PFAC meetings around respectful communication, use of language, interactions? Do you provide training related to DEI practices for both staff and advisors so that everyone understands why it's critical for the PFAC to reflect the diversity of the patient population, and they also learn how they both individually and collectively contribute to an inclusive environment? So there are some hospitals that have begun opening up trainings that might be available to staff, to their advisors as well. The next opportunity is to think about opportunities to partner with advisors in health equity and DEI work. I won't spend a ton of time here other than to say that it's important to bring advisors into work around diversity, equity, inclusion, health disparities, social justice issues. And this can include sharing data about disparities with advisors. We talked to a couple of hospitals that had begun sharing this information, and some of their advisors were very surprised to learn that there were disparities in outcomes and experiences that existed within the hospital. It wasn't something that they had thought about prior to this time. So, if you kind of raise and discuss these issues with advisors, they may have ideas and input about how they can contribute and help address these issues as well. So then the last opportunity, always planning for and building sustainability. This can mean asking hard questions, having challenging conversations, and being willing to work to make improvements. So learning from populations and communities that have been historically underrepresented about why they might not feel comfortable serving as advisors or what some of those barriers are. Learning about your advisors' experiences and what is working for them and what is not working for them. And then also thinking over time about diversity of your PFAC leadership. So if you have PFAC co-chairs or other leaders, it sends a really clear signal if you state that you're working to increase diversity, but your co-chairs or PFAC leads aren't necessarily reflective of that diversity. So just all part of thinking about the things that are going to sustain efforts over time. These are links to a bunch of resources and articles. I'm always happy to talk more about this, but wanted you all to have some links that you could explore in your free time. This is not easy work. I should have prefaced everything by saying that, that this is not easy to do. I can condense this into 6 opportunities for action and talk about them in 15 to 20 minutes. This is work that takes much more effort than that. So I want to acknowledge that this is hard work. Next slide. And then finally, I do want to share one opportunity. So with funding from the Packard Foundation, we are in the process of developing a comprehensive toolkit that will provide guidance and tools related to the opportunities for action that I shared today. This summer, we're going to open up applications for a learning community of hospitals who are interested in advancing DEI. Those hospitals will have access to the comprehensive toolkit before we release it to the public. Monthly educational events and technical assistance. This is a free opportunity, but we are asking for a commitment to not just learning, but also kind of doing the work and setting some specific goals for advancing PFAC DEI practice within your hospitals. But if you are interested in being notified about applications, my email address is there, so please feel free to reach out to me. And that is, I know a lot of information, but that is it for now, and I'm happy to talk further in the breakout rooms.
Great. Thank you so much, Pam. Very, very helpful. Great, thoughtful presentation. All right, so this is our opportunity now to take our group of almost 80 people, and we'll divide ourselves into 2 rooms. So you should get coming up on your screen an option to select a room. The first room will be with Monique and Michael on engaging with leadership, and the second one with Pam on diversifying PFAC membership. We're going to take about 20-25 minutes to chat amongst ourselves, and then we'll come back together for some closing remarks and a wrap up. Hi, thanks everyone. Welcome back. I was in the room on the leadership discussion, and I thought it was really robust. Thank you all for your questions and comments, and I imagine the same was true in the other sessions. So we'll have recordings online and slides, et cetera, et cetera. Just give us a couple of days to process everything, clean it up, and we'll send you out a notice when it's all available. So 3 quick things before we close. I know you're all probably ready for dinner. I just wanted to let you know that we're starting to build out a section of our website that is devoted to PFAC. And I think the 2 key things that you might be interested in is on the left, you see just a screenshot of a tools and resources page that we've put together, and it scrolls down through a number of different content areas. We really scoured the web, found what we could find. And I think what you'll notice is that there's quite a lot of material for starting PFACs and maybe a little bit less for sustaining. And so I'm going to invite all of you to just let me know what resources you're aware of that aren't on the website, things that your PFAC is using that we could share more broadly with the other PFACs in Massachusetts. And then the screenshot on the right, that is the annual reports that most of you have submitted to us back in October, which is great. Healthcare for All kindly shared the archive of reports going back to 2016. So if you're interested in the history of the PFAC that you've joined recently, this is all available and could be of real interest to you. The second thing I wanted to mention is, as Barbara said at the very beginning, this is the first effort to try to get PFAC members together, talking to one another, meeting with one another. And so we're going to plan a forum again in the fall. We have some ideas on what subjects might be of interest. But again, I would invite you to please reach out and let me know if you have any particular ideas. We will send you a survey tomorrow about your experience tonight, and also ask you in that survey if you have any thoughts on some subjects that you think would be really worthwhile for us to all kind of dive in together on. And then finally, in addition to our fabulous speakers, and there were some folks behind the scenes too, both at the Institute for Patient Family Centered Care and at UMass-Memorial, who really helped with the presentations today. So I want to thank them. And also, we put together a small advisory committee about 9 months ago when we decided to start working on PFAC support. And so I just wanted to thank each and every one of them for their time, really thoughtful input, and honestly, their enthusiasm. It's really infectious. So it's been a real pleasure working with them and having all of you here this evening. So thanks very much. And there's my contact. There's our general Betsy Lehman Center contact information. There's my personal email. And I would love to hear from any and all of you. So have a lovely evening, and thank you again.